Well, hello and good afternoon. I want to welcome everyone who's on the call today for our discussion with Phil Kerpen on rolling back DC's healthcare takeover. First, wanted to do a quick introduction of myself and AAF. I'm Joel Grifft. I'm a senior fellow here with a focus on economic policy and advancing American freedom. We're a 501c4. We're an organization advocating for conservative values and policy proposals centering on life, prosperity, strength, and security. We've been doing a series of webinars at AAF on tax, trade, economic policy, and we'll be doing one in a few months on both tariff policy and then family policy. We've had Phil Graham, former Vice President Mike Pence, Vance Ginn, and Lydia Mashburn Newman as just some of our most recent guests. So with that, I want to introduce our guest for today. It's Phil Kerpen. He's the president of American Commitment and also of another wonderful organization, Unleash Prosperity. Both of those organizations are dedicated to free markets and economic growth, sound money, low taxes, and limited government. So Phil has previously served as vice president of policies at Americans for Prosperity and has also worked with the Cato Institute, the Club for Growth, the Free Enterprise Fund. So Phil's done quite a bit over his career, and we're very happy to have you with us here today. And with that, I'm going to thank you, Phil. And with that, I'll pose to you the first question of the afternoon. And as we all are aware, the federal government right now is partially shut down due to debates over the upcoming fiscal year, the fiscal year that actually started several weeks ago. And that debate has centered on the Affordable Care Act, Obamacare subsidy extension. And those are set to expire at the end of this year. And we're aware on this, Democrats are really trying to force Republicans' hand in extending those subsidies. Could you give us an overview of the Obamacare ACA subsidies? How do they actually work? And then go into a bit of detail on the manner in which those subsidies were expanded several years ago during the COVID shutdowns.
Yeah, absolutely. And I just put a chart on my X that has the exact numbers for the subsidy levels, both in the original Obamacare and with the enhanced subsidies. So, I don't have it exactly in front of me, but if you want to see the exact numbers, you can look at that, and I've got it pretty close to that in my head. But this is one of several actually Democratic demands, and they've linked the shutdown, which really is not logically linked to any of their demands, but they've linked the shutdown to a variety of demands. Probably first and foremost among them is these Obamacare subsidies, but they've also said they want to repeal all of the healthcare provisions of the One Big Beautiful Bill, which of course would mean, sort of undoing all of the fixes that we had for Medicaid fraud and a lot of the other reforms and things that were in there, including the provisions to try to crack down on undocumented immigrants being able to get Medicaid. And so that, of course, has been a talking point that Republicans have seized on more so than the Obamacare issue, which is a little bit more challenging. And they've actually had a number of other demands and they've shifted and so forth. But I think you're right, Joel, that their biggest one that they've really locked in on is this idea that we're going to keep the government shut unless you extend the enhanced Obamacare subsidies, the COVID era Obamacare subsidies on top of the regular structure. And one of the things that I think was very poorly considered even in the original Obamacare structure is that the subsidy amounts are not dollar amounts. They're essentially unbounded in terms of the exposure for taxpayers because everyone in Obamacare who qualifies for subsidies pays only a percentage of their income towards the premium, and then all of the rest is charged to taxpayers, however much that might be. And as you can imagine, this creates almost no downward pressure on prices because we've ended up with a marketplace where almost everyone is subsidized, and therefore any increase in premiums is absorbed entirely by taxpayers. And that's one of the reasons there's been absolutely no cost containment and premiums have gone up dramatically because they fall on taxpayers. The enhanced COVID subsidies, which were created by Democrats during COVID. Biden advocated for them. They were passed with no Republican votes. They actually changed these percentages in two very significant ways. One is that there's no longer an upper income limit on qualifying for Obamacare subsidies. So in the regular law, subsidies only go up to 400% of the federal poverty level. Above that, there's no subsidy. So people have to actually pay the premium if they're above 400% of federal poverty. And that at least created some market discipline, albeit for a pretty small number of people, because most people who didn't qualify for subsidy said this is not worth it, and they found healthcare through some other mechanism. But at least there was an upper bound. There is no upper bound under the COVID credits, under the enhanced subsidies. There is no upper bound. So even if you have, let's say you make 600% of the federal poverty, whatever it might be, you could be a very high income person. If the cost of the premiums exceeds 8.5% of your income, you still only pay that 8.5. Taxpayers will pick up the rest. So they got rid of the income limit at the top. The other thing that it did that changed the structure in perhaps an even more corrosive way is, instead of the lowest income people paying about 2% of their income towards premiums, they cut it to zero. And they cut it to zero for everyone up to 150% of the federal poverty level. And this has caused millions of people to sign up, or perhaps more accurately, to be signed up, largely by unscrupulous brokers who are going around telling people, hey, sign up for this, or may even be signing them up without their knowledge. And because they never get a bill and because they never pay anything, people don't object. But the brokers make money, the insurance companies make money, and there's a big difference between requiring even a small payment, say $5 or $10 a week, and zero. And when you require zero, a lot of people who don't value that coverage at all will sign up for it. And in fact, about 40% of all Obamacare plans last year had zero claims filed. And so you got a lot. Now, some of that is just you didn't get sick, you didn't need a doctor that year. So some of that can be valid. But the huge increase, the millions of people increase in zero claim Obamacare enrollees definitely suggests that there's a huge amount of fraud that's gone on. And so one of the best reasons to let these expire is that both of these structural problems would end if the enhanced credits expire. And by the way, Joel, I know I'm rambling a little bit, but the regular subsidies are going to be about $1 trillion over the next decade. The regular subsidies, what we get if the enhanced subsidies expire, are going to be around $1 trillion over the next decade. It's going to be about 1.5 if they extend the enhanced subsidies. So it's an extra $450 billion or so that goes directly to these insurance companies. And if they extend it, it keeps those structural problems, no upper income limit, and lots of people are paying zero. And so that's why I think it's so important that these not be extended, or at the absolute minimum, that if they're extended in some form, they be fixed so that those major structural problems are not extended.
Well, and that really underscores a lot of the problem with the smoke and mirrors in a lot of these federal budget negotiations. Because as we saw during the negotiations with the One Big Beautiful Bill, all of these goals that were hammered out in terms of reducing spending over the next 10 years, that additional $500 billion in subsidies, if these are extended, would undo the majority of the cost savings that conservatives thought they had attained in the One Beautiful Bill negotiating process.
Well, right. It would be a big chunk of it. I think the total Medicaid, it's all tricky because it all depends on what baseline you're looking at and everything like that. Of course, health spending keeps rising every year, even under the One Big Beautiful Bill. But the Medicaid expansion under Biden was very considerable. And so, what we tried to do, what the health provision of the One Big Beautiful Bill tried to do, is sort of alter the trajectory. So instead of Medicaid spending rising, by the 50% that it had in the Biden era, that it would rise, only about 3% a year. And when you get to the end of a decade, it gets you back basically on the trajectory that it was before Biden was president. And of course, I'm kind of skeptical that they'll stick to that. And of course, one of the other big Democratic demands is that the Medicaid reforms be reversed and be undone. So, if the Democrats had everything they wanted, Joel, they would undo the Medicaid reforms from the One Big Beautiful Bill and extend the enhanced Obamacare subsidies, and we would have significantly increased health spending yet again.
All right, so I had another question for you. We know now that the extension is going to be expensive. Again, some might argue, what's $500 billion additional dollars over 10 years when we're spending $6 trillion plus per year? I happen to think it's a very important number, but you've spoken quite a bit about the other repercussions of these subsidies in general, beyond the sticker price to taxpayers. In what other ways is the subsidy system, both the extension, but also as drafted under Obamacare, and in what other ways is that distorting the healthcare system, and how has it impacted things such as premium costs, for instance?
Well, premiums have gone up dramatically, of course, and the costs have been obscured. by the subsidies. And so when they get dumped on taxpayers, there's essentially no market mechanism to put any downward pressure on those prices, particularly when you've eliminated any cap at the top end on income. And so it's been very destructive. And of course, the other challenge that we've got is that most people have very restricted choices because of Obamacare, and so you generally can't get catastrophic health insurance coverage anymore unless you're under the age of 30 or you can qualify for a hardship exemption. And of course, a lot of healthy people would prefer to just have catastrophic coverage, pay out of pocket for routine expenses, that kind of thing, and know that if God forbid something terrible happens, they'll be covered. Well, you can't get it. You can't get that type of coverage the way you used to be able to before Obamacare because it's actually been prohibited. It's been banned other than, as I said, if you're under age 30 or if you qualify for a hardship exemption. And so choices have been really restricted. The benefit designs are extremely prescriptive. And so, even if you look across a bunch of different carriers that are offering plans that are available to you, they're all very similar in general. Networks have gotten extremely constrained because the only way you can really have any kind of cost control in a system where the benefit design is set by government is to limit which providers you include. And so we've seen networks get very, very narrow, and we've also seen deductibles rise. And so the quality of this insurance is very, very poor. And it's ironic because we were told over and over that we needed all these regulations to get rid of junk insurance plans. And the truth is, what we've ended up with for most people is pretty junky because it doesn't cover a lot of the providers that they want to cover. It has a very high deductible that most years they won't even run through, and it's got these enormous premiums. And of course, it's not just people who are in the exchanges that have been affected by all of these issues. It's also in the people who have employer coverage because all of those regulations apply to the employer side as well. And so I think that, it's sad, actually. I think that, the public perception of Obamacare has become kind of positive as people got used to it over time. It just sounds like it's a nice thing, and they see charts how more people are covered. They don't necessarily connect the dots between the fact that the quality of their own coverage has gone down and the fact that it was provisions of Obamacare that did that.
Yeah, and Phil, I know some of this is very old news, of course, regarding the big increases since Obamacare. But I think it's important we keep talking about this because if you're under the age of roughly 38 years old, you don't have a real world awareness of what it was like prior to Obamacare. I'm roughly your age, so I was just out of law school when Obamacare went into effect. I was self-employed, doing a lot of odd jobs, legal and otherwise. I was paying $179 a month for catastrophic insurance that served me well and I broke my leg. And I know for a fact, having looked into this, that if I were to be self-employed today, that $179 policy is not there. It's going to cost closer to $800 per month. But if you're under the age of 38, you don't have a real world awareness of that. And that's why I think it's important that you continue to explain just what you did about the dramatic change that we
Yeah,
saw back in
it's
2000.
yeah, it's very unfortunate. Look, I mean, the the big selling point for Obamacare was that some people were uninsurable before. Some people had pre-existing medical conditions that made them uninsurable, and therefore they said, "Well, we had to turn everything upside down to be able to cover those people." The truth is that even people who are uninsurable, they had last resort pools, high risk pools, high cost subsidized pools in every state, and there were policies available to them, usually administered by Blue Cross Blue Shield. So there were options. Now, those options were very expensive, and they weren't very accessible to a lot of people. So, there were a lot of horror stories of people who had conditions, couldn't find regular commercial insurance, but that was a problem that could have been dealt with in a much more targeted way without turning everything upside down for everyone else. And unfortunately, it's now we've got this knee jerk where anytime someone says, "Hey, we want to fix Obamacare, we want to fix the health insurance system," they say, "Oh my God, they want to bring back pre-existing condition exclusions. They want all these." So that, I think, has been the challenge, is sort of communicating how there were much better ways to deal with that contained problem and still have a well-functioning market for everyone else.
Thanks, Phil. I wanted to talk politics just a little bit before we get into some more substance. Uh, there's a lot of debate right now going on Capitol Hill about whether or not conservatives will find a way to compromise on this, perhaps to provide a short-term subsidy extension or to maybe raise the income limit thresholds. But what do you see as someone who's in politics? What do you see as the potential political repercussions, if any, for conservatives if they remain fully opposed to extending these ACA subsidy enhancements?
Well, look, I mean, I think the challenge will be that Democrats will find people who, there'll probably be people in their 60s but are not yet 65, so they're not Medicare eligible, but they have very high healthcare expenses, and they may have very high incomes. And then they'll say, this person, because they're going from paying, 8.5% of their income to paying uncapped, it's a huge increase. And then they'll sort of try to drive, fear and anger around those stories. The problem I think for the Democrats with trying to do that is that the regular Obamacare subsidies were income related. And again, the income cap would come back in. But if you're talking about people who are over 400% of the federal poverty level, they probably can afford to pay even very high premiums. And so, I think that the number of truly sympathetic people that they'll be able to come up with and use kind of as political stories will not be huge. But all it takes is a few in each state, a few in each congressional district to drive these stories, to use the sympathetic media as a weapon against Republicans, and that can potentially exert pressure and cause some political damage. And that's why I think you are seeing some concern over this and some potential for a cave or some kind of a deal. And there also is just a massive amount of money that's being spent by the health insurance companies as well as by the hospitals and health systems to lobby in favor of extending these subsidies. And so the Washington is being inundated by a massive lobbying push. And so I actually think that the fear perception that there's some huge political consequence is much worse than the reality. I think that's been created by the amount of money that's poured in to this issue. But the fear has been amplified because the health insurance industry has hired a bunch of Republican pollsters and lobbyists, and they've produced numbers and they've used them to scare people. Some of the polling numbers, by the way, are intentionally deceptive. And so, for instance, there's this Kaiser Family Foundation poll that everyone's been waving around everywhere that has some huge percentage of people that say they want the enhanced subsidies extended. But if you pull up the survey instrument, it says that the subsidies are for low and moderate income people. Well, that's not true. They literally want to extend having no income limit at all. And so it could go to very wealthy people. And so when you phrase these questions in a deceptive way, you can drive polling numbers that are not necessarily accurate. I've seen some polls that state it much more neutrally, and they get about 50-50, maybe even a slight majority in favor of letting them expire. And so I don't think this is a massive political liability. But there is a potential, especially if the White House decides they want to do a deal on this, that you will see a compromise and you'll see some kind of extension. And I think there need to be some red lines. In particular, I think you've got to bring back an income limit. It can't be unlimited at the top end. And at the bottom end, you've got to bring back some payment. It cannot be zero. Non-zero is so important to stop the fraudulent enrollments and just to make sure that people actually place at least some value on this coverage. I mean, if you're not willing to pay $5 a week for health insurance coverage, but you're willing to take it if it's free, that coverage is not actually something you value. I'm sorry. And so I think that if we could bring back at least some payments at the bottom end, some income limit at the top end, maybe there's a deal to be done. But I would still want something positive on our side in terms of reforms, something that'll actually bring down costs, bring more choice, bring more competition, bring more transparency. And, if we're going to give up something that could potentially be very expensive, we need to get some policy victories, not just a perceived, political compromise. So I would say, unless you can actually accomplish something positive policy-wise, it's better to just let it expire and try to engage the political fight, or at least fight it to a draw by explaining these things.
Yeah, and when we're talking about these policies for those that for now pay nothing, it's important to keep in mind that even though that policy might only cost that person $5 or $10 a month based on their low income, if that plan would cost you $600 on the marketplace, non-subsidized, that insurance company is pocketing the difference. You're paying nothing. It's not as if they're just receiving that $10 a month from the government. They're receiving the $500, the $600.
Correct. And Joel, that's what's so flawed about a subsidy scheme, both the original one and made much worse by these enhancements. A subsidy scheme that caps what the enrollee pays as a percentage of income, but allows unlimited income growth in the amount that's paid by unlimited growth in the amount that's paid by taxpayers. Well, I mean, that's a recipe for exactly what we've seen, right? The premiums just keep going up and up and up and up. And because almost everyone who's actually in the exchanges qualifies for subsidies, it's the taxpayer that ends up paying for the entirety of the increase that you see every year.
Yeah. So there's a lot of money here to be made for the brokers, for the insurers, which leads me to something I wanted to ask you regarding a study you just completed on AARP and United Healthcare, the money that is flowing from the insurers to now this private organization. Could you dive into that a bit?
Yeah, it's they're much bigger in the Medicare market. They're not really active as the AARP brand in the Obamacare exchanges, but in the Obamacare exchanges, the number one provider is Centene, number two is United Health. So this is a very big business for United Health, probably on the order of $10 billion plus per year. And, I think that is why you're seeing AARP lobby so aggressively in favor of these Obamacare subsidies, which really don't have much significance for their membership, who are mostly in Medicare plans, but are hugely consequential for their big corporate partner. And, we've for a long time been doing these annual studies. When I say we, I mean American Commitment through our Commitment to Seniors project with Chris Jacobs, not the former congressman, the other Chris Jacobs. Who used to work for Jim DeMint. I think the Hill staffers are familiar with him. Juniper Research is his current group now, but he's been every year when AARP's financials come out, we have him analyze them to see how much money they're getting from United Health because that's been their major funding source for several years now. In fact, the last few years, they got about 3 times as much from United Health as they got in membership dues. And they get a lot of membership dues. They get $200 million plus every year in membership dues. We estimate they've been getting about 700 or 800 million from United Health. They stopped disclosing the exact amount in 2019. But just last week, maybe the week before, but very recently, their 2024 financial report came out. And in the notes to that, it says they restructured their royalty arrangement with United Health and they received a one-time payment of $9.06 billion. That's billion with a B. So $9,000 million, $9 billion. It's hard to even conceive of a number this large in kind of the nonprofit advocacy space. One-time payment of $9 billion. I think this probably replaces the 5% of premium skim that they had been taking in previous years. It's not entirely clear if they still have maybe a 1% or whether the 9 billion replaces all of it. I don't know the exact, we don't know. Someone should ask United and AARP for exactly what the deal terms are. But when you get $9 billion as a nonprofit organization, a group that does advocacy work, does political work, it makes you, I don't know, you used to work at Heritage. What are they, 100 million, 200 million a year, something like that? They're the biggest group on the right. And we're talking about an organization now that is, going to be, just in a one-time gift, they're getting 90 times that. I mean, just it's so incomprehensible. I don't even know how you handle it. I assume you get one of the big investment banks to run it for you. I mean, I don't know what you do with $9 billion in a one-time payment, but I mean, AARP, I think it's safe to say at this point, functions as a marketing and advocacy arm of United Health. And I think that's why they've been so active in this Obamacare subsidy debate, kind of from the insurance industry perspective.
Yeah, I think that's a great way to look at the $9 billion, which is a number that I probably won't personally see in my lifetime. But
I mean,
$9 billion, yes,
I don't know what you
it's
do with
enough.
the interest alone could run a nonprofit forever
No,
and
no,
have it be
exactly.
massive.
That's enough if you look at the past financials of the nation's leading right-wing think tanks. That's enough to have funded a handful of them for 40 years
Yeah, I
straight.
mean,
And in terms of, think about what we see in a presidential campaign. It wasn't until recently that a presidential campaign broke $1 billion. We're talking about 9 presidential campaign cycles of advertising and lobbying. So this is massive and
by
just
the way, Joel, that
underscores
also
the
means the sad
amount.
part of that. This also means that no politician's ever going to want to get crosswise with them because they never know if they have the 9 billion. So even though we can shine a spotlight on it and try to make it an issue and make people aware of it, they still have all the money, and so that's a problem.
So I have time for one more question before we get to a few from the audience. With the sticker shock from rising premium costs, the continued deterioration of the availability of affordable care since the passage of Obamacare, we are seeing an increasing number of supposedly mainstream individuals on the left calling for outright socialization or nationalization of the United States healthcare as a solution. Could you go into a bit about, number one, the way in which having this mixed Frankenstein system, a partially free market, partially socialized, is exacerbating the problem? But number two, give us a few examples of how, despite the higher costs that we're paying, the quality of care in terms of efficiency or timeliness of surgeries, for instance, is better here than it is in systems that are completely socialized, like the UK, for instance.
Yeah, look, in a wholly socialized system where you just have the sort of the government bureaucracy that's making the medical decisions, the only way to allocate resources is essentially through central planning and brute force. And so what happens in these systems is they use rationing of care, they delay access to specialists in particular a very long time, and they deny care. And so for joint replacements in the UK are almost completely unavailable. They give you painkillers and a brace, and you live with your bad knee, for the last 10 years of your life. So the quality of life impact is very significant when you have a totally bureaucratized system, and you have to turn to rationing and delay and denial of care. And so we really don't want to go in that direction. The unfortunate thing, Joel, is that we're sort of in a slow motion version of that already, because bad government policies have driven massive consolidation of healthcare systems. We went from almost all physicians being independent and sort of being entrepreneurial and kind of business people running their own practices to almost no physicians being independent now. I think it's down to like 20% or something like that. They've been gobbled up by these giant healthcare systems because the federal government pays more for the same doctor's visit if you're part of a hospital system than if you're independent. That is insane. They also have to deal with all kinds of bureaucracy, all the billing issues, all the electronic records issues. And so it just becomes easier to be an employee. And so we've seen these health systems gobble everything up. Probably the most important thing for Republicans to accomplish on healthcare the next time they do a healthcare bill is site neutral payments for Medicare, to end this idea that if your doctor's practice gets bought by a hospital system, the federal government's going to pay more for the exact same visit, this exact same office visit. That is so destructive, and that's driven all this consolidation. So now you have all this bureaucracy. It's not formally part of government, but it's pretty close, because it's these huge systems. They're heavily dependent on government payments. They're interconnected with government programs, and they're highly bureaucratized. And I think the quality of care has gone down a lot as a consequence of that. And we've also built these huge insurance company bureaucracies that are heavily subsidized. So we don't have that single government bureaucracy, but now you kind of have the interplay of three large bureaucracies in most places, with a huge insurance company bureaucracy, a huge hospital system bureaucracy, and the government bureaucracy. It's not, I don't think, quite as dangerous as just all power being in a single government entity, but it's not very efficient, and it's not very conducive to the quality of care. And so what I've been encouraging conservatives to do on healthcare is to be much more aggressive and say, look, I'm willing to take, don't be in the pocket of any big anything, right? Be willing to take on big pharma, big hospital, big insurance company, big government, and say, look, we want to get back to a functioning market with prices, with people making their own decisions, and with physicians being able to, run their own practice. And I think, if we can kind of start from that place, we can be much more aggressive potentially on some of these policies and get less caught up in the kind of the food fight between these gigantic players and the lobbying contest, where frankly, there aren't usually good guys on any side of those.
You're so right, especially on this issue where you would think that with all the demagoguery by the left and populists against the health insurers, you'd be seeing these share prices take a tumble. You've actually seen the reverse.
They love the insurance. It's so bizarre. The left is so schizophrenic on this issue in particular. Look, they despise United Healthcare so much that they cheered the literal cold-blooded murder of its CEO, right? But they want to shut down the government if we can't send another $10 billion a year to United Health, or whatever the number ends up being in these enhanced subsidies. So they're completely incoherent on this, on kind of whether they love or hate the insurance companies.
I've got time for one additional question for you, Phil, and I don't want to throw you a big curveball. But while we're talking about these subsidies, when it comes to pharmaceuticals, we've seen so much in the news, different proposals from both the left, the right, from the Trump administration included. And of course, we've seen in the past month or so new tariffs that have been threatened on pharmaceutical imports, and now the proposal to put in place some type of price controls as well. What are your thoughts on that? And for those of us who are concerned about pharma prices, what are some free market solutions that Congress could consider implementing in the coming session?
Yeah, with Unleash, we actually have a whole project on this issue we call Most Favored Patient. You can go to mostfavoredpatient.org and read on it. And we've done some polling and some other things. And you're right that the White House, they're a little bit, they're about 80% right, I would say, on drug pricing issues because they do really want to drive competition and transparency. They want to do a lot of the right things. They want to get other rich countries to pay more for brand drugs, which I think is very important and potentially could lead to a lot more new miracle drugs being developed if there's more than one market where you can get a market-based return. That would be huge. But a lot of what they want to accomplish, they want to do through price controls or through threats of tariffs, which are insane. Look, somebody has to explain to me how a 100% tariff on a product can make it less expensive. Mm-hmm. Because that's what the president is literally saying, right? He's saying we want less expensive drugs, so we're going to maybe impose a 100% tariff. Now, I don't think you need to be good at math to know a 100% tariff will double the price of a product. And so the idea that that somehow gets you to a lower price, it takes a very twisted logic chain, I think, to get there. So I do think that that the trade aspect is potentially a way that we improve drug pricing, but more importantly than pricing, the incentive for developing new cures. And what I mean by that is, the other rich countries do not pay market-based prices for brand drugs. They pay government-set prices. And the reason the reason the pharmaceutical companies are willing to sell at those prices is, if you can make your R&D nut back and get a return on capital in the U.S., then you can get accretive profit abroad, even if it's not a market price. As long as it's above your marginal cost, it's extra profit versus not selling there. And so typically they might wait a few years, but eventually they sell into these other rich markets at government set price control prices because it's a little bit of additional profit. Now, if the government of the United States, though, said one of the things that Trump keeps floating, which is we're going to link our price to the lowest price in another rich country automatically, that would totally change the equation, right? Because now a drug manufacturer, when deciding whether to sell into another country at a government set price, they'd say no, right? Because if you say yes to a below market price abroad, and now that drops the price in your primary market to where you can't get back what you spent on R&D, you can't get any return on capital, you destroy your whole business model. So now you're going to say no. So what happens then, I think, is the big question when they say no to selling in these other markets. Then do these other governments issue compulsory licenses and steal their patents? If they do, what does the U.S. do in retaliation to that? And so you have this situation where you're now potentially, maybe nothing. Maybe there's no second order consequence. They just stop selling in these foreign markets. But if you stop selling in foreign markets, now you have less profit because you were selling above marginal cost. So you actually create upward pressure, not downward pressure on the U.S. price. And you potentially create more trade conflict. So what we've been saying is on the trade front, go to these other countries and say, we want you to commit to spending a higher percentage of GDP on brand drugs. That's one of our demands, one of our asks in the context of bilateral trade negotiations. And I think there's a win-win way to do this because almost all of the other rich countries have very restricted generic laws. They're not like us, where once it's off patent, a million generic manufacturers come in and the price drops to $10. They have less generic usage than we do, and they pay twice what we do for generics because they try to protect their generic manufacturers. So if we went to these other rich countries and we said, look, commit to pay more for brand drugs, liberalize your use of generics at the same time, you could actually spend as much or less on drugs overall than you're spending now, but you can contribute towards developing new drugs by paying a market price for brand drugs. And the U.S. price for brand drugs would probably come down a little, especially in classes where there's competition. But more importantly, we'd get many, many new drugs developed if now we double the global return, the global market return on developing new brand drugs. And so that's been our approach on the trade part of this. On the domestic part, I think the really encouraging thing the Trump administration is doing is this idea of having competition with direct-to-consumer sales by pharmaceutical manufacturers. There's a big debate over whether the pharmacies and the PBMs, the pharmacy benefit managers, who are now all owned by the insurance companies, whether they bring more efficiency and lower prices by having, combined buying power, or whether they're just sort of, inefficient middlemen that siphon off to profit. And this has been this huge lobbying battle between both sides. And what I love about the Trump administration approach is you don't have to decide who's right about that lobbying battle. Just say, look, let's have two different sales models. Let's have a direct sales channel, and let's have the pharmacy PBM sales channel, and let people choose which one they want. And whichever one's better for you in a given circumstance is the one you'll use. It'll create downward pressure on prices through both of these channels. And what we've encouraged the Trump administration to do that they've not yet done is they ought to do rulemaking that says that that direct purchases, that cash purchases, non-insurance purchases count towards your deductibles and your out-of-pocket caps. And I think if we did that, we'd put them on a level playing field with the insurance channel, and we'd get much more competition and choice and downward pressure on both. So, and there's some other things in our agenda on drug prices, but this is an area we've actually put a lot of thought and work into. And I would encourage folks to go to mostfavoritedpatient.org, and you can see our stuff on the drug issue.
Well, I want to say a big thank you, Phil. I'm so happy your voice is being heard across the nation on Capitol Hill and in the White House, your wealth of information. And with that, today's webinar does conclude. I want to say a special thank you to all the donors who make it possible for this webinar and all the work that Advancing American Freedom does. And if you want to learn more, please reply to our follow-up email, and you'll receive that after the program. Thank you.